As I said earlier, I had prepared a folder with several things pertaining to that, and I have left it at home. But we're okay. I have duplicates of some of the stuff that I happen to have with me. And the headings, this is it's a different talk, but I'm going to use incest synonymous with sexual trauma. I mean, it doesn't mean that there are no other sexual traumas, and I'll make reference to some of that later as we go along. I'm going to get back to this particular overhead a few times. It's also, I mean, you asked me about, somebody asked me about, you asked me about sexual addictions. I've been doing a lot of work with sexual addictions. In fact, we're one of the few places that treat perpetrators and survivors on the same unit. Sure. And some of the things we've come across, for example, is that a third of the women that come into our program, for example, have either perpetrated themselves or have struggled with it very hard. And when we do very depth work, like doing narco-analysis, which I want to talk in depth during my talk on MPD and dissociation, chemically induced memory and feeling recall, then a lot of people that never talked about it, never talked about being 13 years old and molesting while they were babysitting and things like that, they'll talk about it for the first time. Sexual thoughts, sexual behavior, things that stimulate men and women sexually that were never discussed before. Now, by paraphilias, I mean things where either the direction of sexual excitement, it's either towards, it's not with equal power, or it's in a inhuman, non-human direction. So compulsive masturbation is one form where masturbation in and itself is not it's not something that's abnormal, but compulsive masturbation, the inability to have appropriate intimacy, all of these things then form like a different kind of problem. So the same thing with excessive pornography. Everyone, not everyone, many people may have a certain amount of stimulation watching pornography, but when it becomes the thing and intimacy becomes unbearable in a sense, then it's a problem. All paraphilias, all quote-unquote abnormal sex drives, either whether it has to do with power, as in a person that can only get turned on sexually by children, or in a relationship where they either have to physically or by power hurt a person, as in a sadistic relationship to get sexual excitement, whether it's having to use B words and C words just to get aroused, or the other way around, have to be in a position. All you have to do is open the pages of LA Weekly, and there's like 3 pages of ads for people that want to get beaten on, pissed on, etc., etc. But I'm sure it happens in all cities. I don't mean to say that LA is somehow different. It's just that you can advertise more openly for these things. And so all paraphilic disorders are addictive. And then you have non-paraphilic sexual addiction, which is where there is excessive where sex has gone out of control and is then hurting the person exactly in the nature of a chemical addiction. And then the other thing which is not mentioned here, which I really wanted to focus a lot on, is decreased sex drive, hypophilia, and all that, the connection with that. In fact, when you look at it, most people that have been sexually traumatized don't have a lot of, ultimately, they're not having that much healthy sexual joy in their lives. Especially in their 30s and 40s and 50s, they are going into lesser and lesser capacity to enjoy sex. Okay? And that's the pattern. So a decreased sex drive, rather than a decreased capacity towards intimacy, and sexual intimacy is the rule among sexual survivors, not the other way around. And that is just, I call it a no-sex addiction. We are addicted to no sex. So no sex addiction. And no sex addiction is much more prevalent than sex addiction. And to me, it's really the reverse of the same problem, and it needs to be addressed the same way. In fact, I will tell people to go and attend, I will tell my no-sex addicts to go and attend sexual addiction meetings. That's where they need to be, because they are repressing a tremendous amount of thoughts and feelings. It's very prohibitive to them. And when they attend sexual addict meetings, then what the other people are going to talk about will start stirring up things inside themselves. And for the first time in years, sometimes 5, 10, 15 years, they can start awakening their own sexuality. And very, very important, because if a person doesn't awake, the book that I'm working on very actively right now, it's on sexual trauma and sexual healing, and with the need for being able to come to a point of enjoying healthy sexuality as a significant goal in recovery for us as individuals, and a goal for our patients, if we're clinicians, to get to. And if you do not get them there, in a sense, they're always prone towards relapse. If you do not get a person to a point where they are able to be sexually intimate, then they're at risk for relapsing either into chemical addictions, food, workaholism, codependency, or some kind of relapse. Okay? So, okay. Undiagnosed and untreated. Can everybody see what's written here? Undiagnosed sexual trauma leads to chronic states or relapses in chemical dependency, alcoholism, eating disorders, sexual addictions, and self-mutilation. So, when you look at any one of these things, you want to look at the possibility of sexual trauma. And I don't have all the numbers here, but it's very, very high. When you look at, for a long time, we didn't primarily have a chemical dependency treatment program. Now we do. And we have a large number of people that come into the program that have been, that have a history of trauma and some kind of sexual imbalance problem. Very high. All of these disorders. I mean, so again, I put down self-mutilation because self-mutilation also is an addictive process. Okay? Self-mutilation is many things. It is many things to many people. It can also be many things for the same person. It can be used differently at different times. It can be injuring the self. It can be a way of getting excited. There is the same level of excitement, endorphin release, and drop with the kind of depression that follows in people that have self-mutilation. It definitely is an addictive quality to it. We see a lot of, we don't hospitalize people because they have self-mutilation. Probably 50 to 60% of our patients have or have had problems with self-mutilation. I mean, I say have because it's always prone to resurface unless you're finding other ways to deal with it. And as I will talk about it later, the need to do depth work and including memory and affect retrieval, and especially to do body work. To me, body work is critical. So what I will tell people is that if you're unwilling to do body work, you shouldn't come into the program. That if you cannot accept hands-on work, and it's not that I go on giving hugs and stroking people, but essentially if you're unwilling to do body work, then there are certain kinds of problems, including sexual addictions, that we simply cannot treat. And that's the truth. I mean, we cannot treat them if we feel that their recovery will be hampered significantly if they do not engage, if you're not having body work done with them. A person may be sexually acting out, or a person may be totally devoid of any sexual activity, and they contain all this fear in their body. Either they're overeating or undereating or over-exercising, and they're all, they are having perfect figures, but and maybe they have a kind of sex that they do at people, but can't be sexual in any real intimacy. So for all of that, you really have to do body work, because body work, the premise of my book is that it is the nonverbal wounds that are critical towards long-term problems, especially addictions and a lot of psychiatric illnesses. That essentially, that it's the things that happen before the age of 3, before the age of 4, that then set the pattern for how things will be reacted to later and how the world will be seen later. And these early experiences, I mean, I'm sure I'm not saying anything new by that. The early experience of tremendous bearing. And when you look at bright and motivated people, movement and addictions and certain kind of depression, anxiety problems, if they could be reasoned through, which is why I am not a great fan of cognitive therapy and all of this stuff. But if you don't work at the nonverbal level, because if people could read a book and talk themselves out of it, they'd be doing it all the time. I mean, we know that people are not able to do that. Bright people, most of the people that come into our program are, one of the advantages, we take only people that have insurance and can pay cash. So there's a self-selection that takes place. Most of them have been in recovery for some time from chemical addictions and things like that. But we can see these people struggle, and they have all the intellectual tools, but it is because of things that are at a bodily level that they cannot make movement. And with these disorders, it's critical that we use the body work. Okay. Now, all of these cross over are concurrent with codependency, physical illness, sexual aversion, work addiction, and religiosity. Well, we talked about the physical illness. I want to spend a little bit of time on. Sexual trauma often, for a lot of people with sexual trauma, they're not going to talk about it. What we see is physical problems. In fact, I give a whole talk on the physical symptoms related to child abuse and sexual trauma. But somatoform disorders, for example, which is the physical illnesses of various parts of the body, are the number one symptom in people that suffer from childhood abuse, and which is why in my earlier talk today I had mentioned. So there may be a very high level of physical symptom complaints in this population, and that also becomes, especially in women, that becomes a reason for being addicted to prescription medications. Okay? Migraine headaches, irritable bowel syndrome, painful menses, back pain, of course, mitral valve prolapse kind of symptoms, dizziness and palpitations and feeling you're going to pass out. So there's a whole host of physical symptoms that present, that are common in people that have addictions, where sexual trauma is at the root of all of this. Incest trauma remains unaddressed after years of treatment because of psychogenic amnesia. I mean sexual trauma, but because of psychogenic amnesia, because of therapist denial, and society's denial of such trauma. I mean, as I spoke earlier today, there's still people that maintain that people just think up these things. In California, we had a case just. It was from New York, but it was in the newspaper about a lady that went and told a therapist that her parents had drowned her 4-year-old sister, and she had witnessed it. When she was 6 or 9 years old, she had witnessed her mother and father holding her sister down in the bathtub until she turned blue and died, and she was repeatedly beaten. They believed that she was possessed, and they repeatedly beat her, abused her a lot, and finally drowned her. And they took her to Mexico and buried her. So this kind of thing, it's very, there was no body and stuff involved. And there's a lot of skepticism about people remembering. And so we talked about this false memory syndrome society. And yet, because people don't remember sexual trauma, don't remember incest, for a variety of reasons. One is there is sex. It is often done with somebody that is the closest person to them. In a family where the mother is walking around with severe depression, has no affect, has no connectedness to the child, an alcoholic father might be the only one that brings life into the house. And therefore, the child may be drawn to that alcoholic father, stepfather, uncle, in a seeing that as a source of energy, of positive energy, and then take on all the blame of what happens with them sexually. So, incest and sexual trauma, especially incest, but sexual trauma in general, and the earlier it happens, has a tendency to be repressed. Hyperamnesia. Hyperamnesia is much more common for people with sexual trauma at an early age than it is for other kinds of physical abuse. And in our work, one of the things we've noticed, I have been doing this thing since 1983. Specifically working on sexual trauma and trauma in general, but sexual trauma in particular. And what we have seen is that when we do intensive memory work, people start remembering things like abuses, date rapes, being molested by teachers, then stepfathers, then uncles, and then it may take years to remember being molested by somebody very, very close, like a parent, like a father or a grandfather. It takes even more time because it's very, very, very deep, because of the deeply confusing and conflicting nature of those feelings and how much of themselves they've integrated to that. How much of their body and their lifestyle is all connected to that. So the amnesia is definitely more, and society's denial. It takes an average of 8 to 13 years for people with serious childhood sexual trauma-related disorders to be identified as such. Yeah, 8 to 13 years of therapy. If you're familiar with the work of Michael Stone, who's one of the well-known authorities on the treatment of borderline personality disorder, he has written a chapter in a book called The Treatment of Sexual Abuse Survivors. And he has said that it takes an average of 8 years of intensive therapy with periodic hospitalizations to overcome incest trauma wounds. And my question is, where's all the money going to come from? There are certainly more incest survivors and sexual trauma survivors than there are therapists. And of course, there are at least the same representation percentage-wise of people who are therapists who are also trauma sufferers. Makes it all complicated, and that's the reason why we push self-help so much. All help, in a sense, has to be geared towards self-help for the person to recover, because trauma is too pervasive for people to have to go into therapy for 8 and 10 years to get better, and we have to find better ways. And in my book I have said that it's not good to be in therapy for more than a year, and I have taken a lot of heat for that, from all my friends and my not-so-friends, because I had to come up with some kind of time frame, and I felt a year, and this was gleaned from our experience working as a unit, as a clinician, as a unit. We have had approximately 500 hospitalizations in a 4-year period, okay, and we have had a recidivism of less than 3%. We do very, very well, and a lot of them have been in other programs, eating disorder programs, chemical dependency programs, all of this. We have very, very little recidivism in our program. So I know that some of the things that we are doing and insisting on doing difference. And when I put the 1-year time frame, it was about using all modalities towards getting better, not just therapy. And the insistence on the part of the therapist should be, you have to use the modalities. For example, someone that chooses not to go to 12-step meetings should not be an individual therapy. And as far as I can see that, if there isn't a nudging in that direction, where a therapist says, I know it's very frightening for you to go to a 12-step meeting, you see people that are not like you, I know you're afraid of leaving your home and all of that, and yet if you don't make it happen, I can't help you. And I'll say the same thing with body work. You know, you are 150 pounds overweight, you haven't had sex in the last 7 years, you know, and you've been going to all kind of therapies and all kind of workshops, but if you don't start getting body work, I can't work with you. Increasing the sessions from once a week to 3 times a week is not going to do it. Okay? So once we are able to tell honestly, if you believe that, and again, because I believe it completely, I will tell the patients that, because I really believe that if you don't do body work, you're going to be stuck in therapy. Maybe they'll find a different therapist, but they will not make movement, and they will always be vulnerable towards backsliding. Okay? Whereas if they get past the body work place, they will be in a position where they will never slide back that completely. They will reach a different plateau of recovery once, because if in fact you cannot trust your body and your body feels so damaged that you cannot allow another person to touch it, cannot get an embrace, because an embrace and touching are the concrete manifestations of our love and trust. And if you cannot get to that point in time, we are still carrying a tremendous amount of distrust, okay? No matter how much therapy has gone on. And so I will confront them with my powerlessness in changing their lives at that point in time, and tell them perhaps 3 months down the line, perhaps 6 months down the line, you may feel in a different position, and perhaps by that time you will feel desperate enough to want to do this. And I think that we also have to push what I call a positive sense of desperation. Though sexual trauma and abuse are all man-made conditions in a sense, and can be unlike so-called, unlike schizophrenia and manic depressive illness and some of the things that we see more as biological illnesses that need a lifetime of medications, and sexual trauma which may be mistaken for that, child abuse trauma that may be mistaken for some of these conditions. The truth is, childhood trauma and sexual trauma can be overcome without medications and by self-healing over a period of time. And that is, I think that many of you probably from your own experiences know that. We definitely know from the literature. I mean, we had Maya Angelou read a poem at this inauguration. We all know about her. I mean, I don't know if you know her story, but she was mute for several years after her sexual trauma. I think the examples of people that are traumatized and overcome without medications and without therapy, which I think is what happens to most people. I think most trauma survivors get to where the largest percentage self-heal. They self-heal because they get the good fortune to perhaps have some positive friendships here and there. They're able to pick up things in nature, things among their friendships that allow them to work through their process. Perhaps a good relationship that allows them to heal over a lifetime. Maybe one abusive relationship physically turns into an emotionally abusive relationship in the second one, and maybe a healthy one in the third relationship. So there is a growth through relationships and all of that, which is healing. And so I think that push has to be there, the push towards getting self-help in this kind of trauma. Okay. Some of the things: amnesia, denial, affect disconnection, somatization, and I wrote down bipolar disorder. I really mean like mood swings. These are mood swings become a way in which the incest trauma is dealt with without really working on it. And these are also common to people that have chemical and other addictions. Incest survivors and addictions and addicts is misdiagnosed. They're misdiagnosed as having borderline personality disorder. I wrote down codependency. Codependency, when you look at codependency, you're really talking about several personality disorders. Dependent personality, it's actually a mixed personality disorder with various blends of narcissistic personality disorder, antisocial personality disorder, borderline personality disorder, histrionic personality disorder, passive-aggressive and dependent personality disorder, and self-defeating personalities. So to me, codependency is really a grab bag of personalities, where the basic problem is one of a lack of self-esteem, a lack of a capacity for self-soothing, and not being able to play. Not being able to play, not being able to be self-soothed, and not being able to, a boundary problem. Self-awareness, self-soothing, and an impaired capacity to play. If I'm sounding too left field, you're welcome to stop me. This is after a workshop. It's a dialogue. Okay. And both of these conditions are prone to mistreatment. Being given medication like Valium. We talked about major tranquilizers this morning, which are very, very... I started ASCA in 1985 purely out of after having medicated patients early on in my career, and then really working with borderline patients for a long period of time, where these problems overlap: addiction, sexual addiction, and incest and sexual trauma all overlap. I came to realize what a large percentage of them, either as in their youth or in their young adulthood, and with the young adults, had been treated with major tranquilizers. And I was greatly concerned. And it was my concern about the abuse of major tranquilizers in borderline patients who I recognize as sexual trauma survivors that really caused me to bring on this organization called ASCA, which stands for Adult Survivors of Child Abuse, because I wanted them to be educated about it. So what we had was really large groups that we would just give information, not really meaning to start a program or anything. And that still remains a major concern. There is a need for focused 12-step work, including memory retrieval, body work, the treatment of learned helplessness, the treatment for sexuality, are essential for preventing chronicity, relapses, and end-stage complications of both of these conditions, like death, disability, cardiac problems, cerebrovascular problems, and organic brain disorder, which are really the end-stage problems of people that have sexual trauma, chemical addictions overlap, or addiction overlap. When we talk about sexual trauma, and later this afternoon I'm going to talk about trauma in general, trauma in a different level when I talk of dissociation and MPD. So I'm not going to get into trauma itself as much here. I'm going to stay more specific with sexual trauma. So who are sexual trauma survivors? The nature of sexual wounding. Incest and childhood sexual abuse, of course, is a very form of sexual trauma. But then there are other things like the ACA picture, okay, where you have a mother that is very, very disempowered, a father that is very abusive, either emotionally or physically or both, a kind of where this sense of the female being demolished, being damaged all the time is a constant presence. When you have to live and sleep through nights of not knowing whether your father is going to kill your mother, when all you hear from the time that he comes back in his drunken rage is having her face slammed against the wall or being called B words and C words, okay? And that is your sense of femininity. As a man and as a woman, as a boy and as a girl, one sense of sexuality gets damaged. Instead of being able to celebrate and feel good about one's sexuality, they become things that we are crippled with, things that become a baggage for us. So ACA and ACA-like environments, and by that I mean rageaholic homes, by that I mean hyper-religious homes, okay, because to me religiosity always has to do with sexual addictions. There is always, and I mean, I am not at all surprised when you hear about all the things that are coming out of the Catholic Church and stuff like that, Their own statistics are very clear. And to me, there is a much higher level of people with sexual addictions that are in the Catholic Church, because we are not talking about a general population. If you happen to find Fenner's magazine at 7-Eleven, and if you're an average 18 or 25 or 30 or 40-year-old, you probably will not have a major hang-up about going and masturbating looking at it. But in a situation where all sexual thought is prohibited and seen as ungodly and majorly disconnected from spiritual life, when that is the mold, then it is a self-selected population that goes there. There are much more people with a history of sexual trauma who are struggling with their devils, who are struggling with their impulses, that go towards the Catholic Church in the hope of a safe haven. And then, because you can't just get rid of it, they create a double life. Okay? Either a double life that's all in their head, or a double life that is sometimes in their head, sometimes acted out, or mostly in the head with periods of intense acting out. Okay? Which is a pattern that you see. If you remember from 3 years back, the Archbishop that was in the South, I think it was in Georgia, went out to investigate a sexual molestation of one of the lay women by another priest, and himself got involved with her and made her pregnant. So this is all over 20 and 60 minutes and all of that. But again, I'm not getting on the people, but there is a need. I mean, the Catholic Church and the Church in general definitely contributes towards sexual abuse, contributes towards child abuse to some degree, and definitely contributes towards the abuse of women and sexual abuse. In denying, again, I want you to feel free in expressing your feelings about these. When a religion does not have God in the shape of a woman, and only has God in the shape of a man, then women and femininity and female sexuality, or sexuality in general, because God has nothing below his head, becomes something that cannot be connected to the wholeness, to goodness. And you start out from the premise that's bad, and that in itself is endangering and abusive towards the development of one's healthy sexuality, because we have to see sexuality as one petal of the flower that we are, and we cannot see it as something that's distinct. And all of ourselves, including our spirituality, is dependent on that. There is a saying in one of the books that this is one of the books that was written in India, that of all the places of pilgrimage, none is more holier than the body of the woman. And I think that the emphasis is that one's sexuality, and I can say the same thing for men, but the emphasis on the sexual being as good as the rest of the individual is a very important one, and that is how, in not putting it out there, the Church, in a sense, abuses people sexually, and that is picked up at a societal level, picked up at an individual level, and used to create abuse. When you find hyper-religious environments, you're looking towards a massive distortion of sexual ideas. And you're also looking for covert sexual abuse. I mean, there is not one, but literally 30, 40, 50 cases where the religious abuse would be distinctly connected with sexual abuse. People having sex with their daughters or their stepdaughters, then beating them up, having them pray, all of this ritual. Okay, so that's what I mean, negative and non-glorious sexual attitudes. Then maternal depression and deprivation. That can also be abusive, because when there is an inability on the part of the mother to have a sense of joy and wonder in her eyes and in her body language towards the child, the physical form of the child is not accepted as a whole. If there is a focus on certain parts of the body not being given the same kind of attention, caring, and if her attitudes and her lack of energy is displaced onto the child, then you're going to have a child that doesn't feel good about its body. And in certain critical stages of psychosexual development, the sense of one's genitals and genital development are very, very important. If you look at the whole literature on paraphilias and things like that, that's what you see, where because there has been a damage to the person as a whole, sometimes the capacity to feel sexual becomes the most important thing in a person's life. And when there is a damage to the total self, one's sexuality is also damaged, and it needs to be attended to. So that's how, when mothers feel overwhelmed or depressed, they cannot sustain a positive body image formation and healthy sexual attitude formation in the child. A mother that feels bad about her femininity is not going to be able to create healthy sexuality in her infant child. A mother that has a tremendous sense of rage towards men coming from her own life will not be able to give the appropriate nurturing for sexual development to a man-child or a female child. And these are all subtle, discrete forms. And this is where the history taking becomes so important. I mean, for those of you that are clinicians, it is really, really critical that a history of infancy be really gone into in depth, including the emotional state of the mother. And I don't mean to get on the case of mothers at all. I mean, I think that mothers are not supported adequately in the kind of society that we live in right now. And when I'm talking about the mothering process, which consists of the father or whoever, the male parent, or if it is not a heterosexual relationship, that there is a balance of mothering and the parenting the child feel worthwhile, makes the child feel loved, makes the child feel cherished, and these are significant steps in development of one's sexuality. Again, we talked about domestic violence and emasculation. When a child grows up seeing his mother being beaten up and not being able to protect what at one level is the closest connection in the child's being, there is a sense of emasculation that eventually will either lead to a lot of sexual problems, as in not being able to perform, or a tendency to be abusive sexually, as in commit rape and coercive sexual behaviors, or use alcohol to try to deal with both, alcohol or drugs to try to deal with both not being able to be sexually aroused or not being able to deal with uncontrollable sexual impulses. In a sense, then, all abuse is sexual abuse, and all abuse is spiritual abuse. And then there is also with partners, as in partners not realizing the sense of wounding that may have taken place in incest survivors and prolonging the abuse and often driving incest survivors into chemical dependency problems. This is what I had was a 100-patient study that I had put down graphically, which I don't have with me at this time, but these were some of the examples in that 100 patients, and what we looked at was the degree of chemical dependency involvement with people that came from sexual trauma. We also did another study of 25 patients, following them for a 3-year period. Out of these 25 patients that came into a unit, 21 were chemically dependent, and 4 were non-chemically dependent. 9 had what we described as paraphilic addictions, and 16 were non-paraphilic. And what we found out was that the people, over a long term, the people that did 12-step work in both areas, both chemical dependency, alcohol, AA, and who attended incest survivors and sexual addiction meetings, were the ones that remained sober, chemically sober in their sexual acting out, and overall had a better quality of life. And we also found out that the body work was critical, and we also found out that people that embarked on these kind of things but never got to a point of sexual recovery, as in terms of losing weight, feeling good about their bodies, taking a chance on relationships and intimacy, were also the ones that had longer periods of depression or a tendency towards using prescription medications. Are you all with me? Okay. This is, I wanted to use this, 7 patients, looking at them over the years, how addictions kind of transform. GT, in her teens, she has eating disorders, chemical dependency, and when I put W, it's for school. You know? Major involved, doing very well in school, like super academic. In her 20s, it was sexual addictions, chemical dependency, and eating addiction, eating disorder. And in her 30s, it's sexual aversion, what I talked about earlier, not wanting to be, staying away from sex completely. In her 30s, sexual aversion, workaholism, and relationship addictions. Okay. KH. In teens, chemical dependency, again, these are all incest survivors. Chemical dependency in teens, sexual acting out in teens, and eating disorder in teens, followed by in the 20s, eating disorder and chemical dependency. And in the 30s, so by the time she was primarily chemical dependency and eating disorders without any sex in her life. And by the 30s, so we're talking about somebody that's in recovery since her 20s, okay? And in her 30s, she's still a workaholic, eating disorder, and sexually aversive. The only thing that she's not at this point in time is she's not chemically dependent. Okay. Number 3, in the teens again, eating disorder. In the 20s, sexual addiction, chemical dependency, and eating disorder. And in the 30s again, sexual aversion, codependency, and eating disorder. MT is for chemical dependency in teens, chemical dependency and sexual addiction in the 20s, and codependency and pain problems, what I call an addiction to pain. Pain, talking about pain, living pain. It's like some people are there, you know, it's like 1962, they lifted a box while they were working for the county, and ever since then, they're on the seat watching TV for the next 20 years and constantly thinking about the pain. It is when you don't have enough things going on within yourself in terms of being able to play and be creative, then pain becomes a focus. I tell people all the time, all pain is a perception. We as clinicians and as physicians, we sometimes say, oh, that pain is not real. You know, this pain is real, that pain's not real. Well, if you want to look at it, no pain is real or all pain is real, because pain is always a perception. Unlike touch, if you stroke somebody with a feather, or you put vibrations there, or you put hot and cold, which goes all the way to the top of the brain in terms of the highest levels of the cortex, pain doesn't go there. Pain is always a perception. Pain, whether it is your foot being sawn off or somebody pinching you, ultimately goes up to the thalamus, and that's where it sits, and then the rest of the brain kind of puts it together and tries to make sense out of it. So there may be somebody who's getting the nipples bitten off that may not be in pain and may be in sexual excitement, or there may be somebody else that is able to lift a car, and irregardless of how much pain they have, because their mind doesn't read it as pain. And there may be somebody else who has a pain in their back that becomes a focus of their whole lives, and that's what I mean, an addiction to pain. Okay. EP, again, chemical dependency in teens, chemical dependency in eating disorder in 20s, work and codependency in the 30s. With MT, I also have in the 50s, pain, eating disorder, and sexual aversion. In the case number 6, we got CD and SA in teens, CD, SA, and pain problems in 20s, CD, sexual aversion, pain, and relationship problems in the 30s. JL, chemical dependency in teens, sexual addictions, and oops. Okay. No. What would that stand for? No, I'd have to look to my. It's not pain. What's that? No, physical illness. Thank you. It's physical illness. Yeah. So a progression to physical illnesses. No, that becomes a major focus. I mean, if you look at it, for example, 40% of people. Thank you. Appreciate it. The stress. No? Yeah. Anyway, 40% of people with irritable, talking about physical illnesses, 40% of people with who have a history of irritable bowel syndrome, people that have pelvic problems, chronic pelvic, multiple pelvic cysts, and laparoscopies. People that have had laparoscopies, multiple laparoscopies, more than one laparoscopy, have a recalled history of sexual trauma. And so we're not talking about all those people that have psychogenic amnesia, because a very large percentage of people that have been sexually traumatized don't remember that. But just the recall, my sense is that a much larger population of people with pelvic symptoms have history, and with irritable bowel syndrome. 1/3 of people with irritable bowel syndrome, which after headache is the #1 reason for loss of earnings in this country. Work days lost next to headaches. Irritable bowel syndrome is the number one financially losing kind of problem that we have. But 1/3 of them have a history of sexual trauma, and that is recalled sexual trauma. So the physical illnesses, again, they almost have an addictive quality. They take on a large meaning in a person's life, and they get hooked to their illness. And one has to address it just as a... so if a person, again, in their 30s and 40s is having these physical problems, we need them to get better. It is an indicator of unresolved trauma, and in a sense has an addictive quality to it, and also promotes the use of prescription medications. I mean, Librax, when you talk about these are belladonna and barbiturate compounds that are used, and I find people, even within the recovering community, that excuse themselves from using this, because my gastroenterologist told me, you've got to take this, because you have spasms in your stomach, and these are all addictive medications. We're going to talk briefly on the treatment of, yes. There's always, since we're talking about addictions, and there is always some degree of depression. I mean, affective disorders, depression and mood problems are like the #1 thing. Actually, it's the #2 thing in the population of sexual trauma. Depression is always there. The reason why I haven't referred to depression constantly in this talk is we were talking about sexual trauma and chemical dependency. But depression is there all the time. Either it's very overt or it's not so overt. Now, in somebody that has, you've seen fat and jolly people. They're always smiling, but the depression's still there. And physical illnesses and chemical dependency and eating disorders take the place of depression. So you may not find overt depression, and what happens is when you start working on these problems, overt depression sets in. So we will constantly see people that have never felt suicide in their lives, at least at a conscious level. They come into the program, start working with either losing weight or these kind of things, and they start experiencing depression. So the eating disorder, the chemical dependency, is a way to ward off clinical depression, as in all of these things. So depression is always there at some level and has to be dealt with. And in the treatment, you want to take somebody that is, as I call, fat and giggly, and get them to a point of depression, so that they will get in touch, do their work of rage, do the work of grief, get in touch with their trauma, and then to be able to get beyond it and come to a point of healthy sexuality and balanced capacity to nurture and eat and all of these things. Okay. Yes?
With your research program, do you stop a lot of the things people use to medicate commonly in the program, such as cigarettes,
Yeah, the question is, what do we do in terms of people with other addictions like cigarettes and caffeine and stuff? It's a non-smoking environment, and unless we are prepared to provide a smoking treatment component, which we are not, I would not feel right about stopping it. But we don't let them smoke in the premises. We don't let, it's a smoke-free. All the inpatient and outpatient treatment programs are all smoke-free. And they don't serve caffeinated drinks. But can somebody walk over to the and get 6 cans of Diet Pepsi and get all, jazzed up, that's a whole different story. And I know that happens, and it has to be addressed. Relationship. Relationship, yeah. Yeah, relationship. But now that you mention it, religious addiction is very high in this group too, meaning the people that have sexual trauma, and that is often a pattern. Sexual trauma in childhood and adolescence, chemical dependency in teens and 20s, and religious addiction in 30s and 40s and 50s. Very, very common. And so by the time they're in the religious addiction, they often start inflicting abusive attitude towards their children. So when you have a situation where there is religious addiction, the child and sexuality is drowned out of the family, there are no healthy sexual models for the child to connect to. So such a child then gets drawn towards unhealthy sexual models, because it is in seeing or getting a sense of the sexuality between one's parents, this healthy, dynamic, positive, glowing kind of sexuality that comes from individuals that are having healthy sexual life, that allows the child to sense at several levels that this is something positive, okay? And it grows in the child. And when it's not there, then the child is going to look towards dysfunctional ways of creating that model. Okay. I'm really glad that you brought it up. Yes. Okay, I'm going to talk a little bit about treatment. Just going to run through it real quick and leave some time for questions. One is to stop the abuse, addictions, and relationships, and any kind of work that is abusive. To attend trauma-specific groups, and to also get a sponsor. And I think getting a sponsor is really, really critical, because as I said earlier, it shows a higher level of commitment. You cannot, since dissociation is such a common problem in this group, getting a sponsor calls for a greater level of commitment. You can't just kind of eat the donuts, drink the coffee, and head out of the 12-step meetings. And we insist on people getting, so things for reasons for why we will not see people after a period of time will be things like that, not getting a sponsor, because that makes a person not accountable, and we let them go on and on without a sponsor. We know they're not really working the steps. And if they're not working the steps, you don't want to be part of an enabling process. So it is better to drop them and let them come to a point where they feel like they really need to do it. So then doing a lot of the inner child work, I'm just using a kind of generic term. I hope that you know what I mean by trauma-specific groups, which means if a person has chemical dependency problems and some concern about sexual trauma, even the possibility, then they need to attend sexual trauma groups. They may need to attend groups for people that have perpetrator issues. Okay? If a person has perpetrator thoughts and have chemical dependency problems, they need to go to perpetrator meetings, because having other people with perpetration problems talking is an important ingredient in opening up their own memories and feelings. And if they don't do that, they're going to be stuck with their chemical dependency orders. There'll come plenty of guys, like majorly abusing food, majorly overworking, and they may have never done anything, but they're struggling with the thoughts, and they have used food or chemicals as a way of dealing with it. And then when they go for perpetrator things, they start opening up, and that's really, really critical. So all of this helps cut down treatment time. Okay? Makes for faster movement. Okay, memory work. Again, the big emphasis in our program, and much of my work, is the need to remember, both remembering in terms of picture memories, but also feeling memories. So this is where we have drawn some heat. Our emphasis on the three things we've drawn heat on: our emphasis on remembering, our emphasis on body work, and our emphasis on confrontation. These are not popular positions, but we feel like it's critical. Again, taking the time, because if you don't take the time for yourself, person's not going to be able to do the memory work. One cannot make a journey into oneself if there isn't time taken. to explore dreams, to look at nightmares, flashbacks, fantasies, auditory hallucinations, explore bodily memories, to look into artwork and art therapy and journaling, to look at non-dominant handwriting. I'm sure that many of you are familiar with these concepts. Using auto-hypnosis. Again, what is hypnosis? I mean, I talked to somebody earlier today if I believed in hypnosis. I mean, it's not so much like belief, you know, but what's hypnosis? And hypnosis is not something that comes out of the therapist's fingers into the other person's brain. It's really teaching an individual how to use a technique for them to either calm themselves down or allow them to go into spaces which they need to go into to understand what's going on with them, to give them the tools to negotiate things in their mind, to explore things in their mind and feel safe. That's what it's about. It's not about things being done to them, because we have, again, a lot of Christian therapy programs that don't want people to have hypnosis, and it's not about influencing a person's mind. It's about giving them a tool. So, very helpful for people that want to do the memory work and overcome trauma. And I've written down, visit and talk to the past again, finding ways to reconnect, talking to siblings, talking to friends, talking to neighbors, all of that as a way of connecting to things from the past. While there is so much, a lot of people come into the program or come into therapy with a lot of alienation from their siblings, and yet all of their siblings, even the disconnected ones, are survivors, you know. When it is like an explosion, when you go through a holocaust, everybody kind of goes into the shell. Everybody's in terror, and people just disappear in different parts of the country, and they don't keep in touch, and they feel alienated. And yet there is often a lot of connectedness that can be tapped once we encourage that connection. So I tell people all the time, call your brother, call your sister. You don't know. I haven't talked to them in 20 years. I haven't talked to them in 5 years. You know, and yet you know there is a connection. And we find wonderful results when people do this kind of work. Again, I've mentioned one. I have written down under memory work, the need to do confrontation. And my experience is that when people don't do confrontation, then in a sense they continue to be abused. Okay, and if you have to go to your stepfather and your mother's home for Thanksgiving and Christmas, and maybe he looks a little weaker, maybe he breathes a little harder, but this is the same person that has abused you and has never made amends. And as you sit there in front of him and talk about the weather and your grandson and his grandson, you are still being abused, because you still have not made your testimony. You have still not come up with your truth, and you still live a lie, and you have muffled the voice of that child inside you. So confrontation. So I will tell people, for example, remember, talk to them about it. You may not want to talk about incest, but you can talk about the things that you very, very clearly remember, the coldness, the domestic violence. And when you start with that, the other feelings and memories will become more real. So what confrontation does, it peels away the level of denial and makes the memories and feelings that are under the layers more and more clearer. So, for example, then we will tell patients that if you don't do confrontation like in 2 months or 3 months, you know, to build up to this time, then we don't want you in individual treatment. We will see a lack of confrontation as a lack of initiative, taking, and accountability. Because if you cannot confront your father or your stepfather or your mother, you are not going to be confronting your relationship. You're not going to be confronting your son. You're not going to be confronting your boss. And you will stay pigeonholed in with the sense of learned helplessness. Okay? So, unless there is a potential for physical threats and things like that. I mean, you know, you certainly don't want to get self-destructive and go and talk to your stepfather, tell the patient to go and talk to the stepfathers who may start beating her up or something like that. So confrontation is important towards memory work, grief work and rage work, psychodrama, again, helpful techniques, explore creative play, explore the creative self, taking time to play. Again, as with all addictions, the inability to play, because a person loses all of themselves in play. Play is what, for children and for adults, when we are children we play. And then when we are adults, some of it transforms into work, because work is like creative play, okay? And not drudgery, not something that's done with the noose around one's neck and somebody else's schedule. It is when we cannot dream on our own that we are living somebody else's dreams and working for someone. Otherwise, there is synchrony between what we do and the other person does. And so learning how to, really, getting into play is a critical step in healing from addictions and incest trauma. Taking the risk at some point in time, taking the risk of relationships, sexuality, and having children. Okay. It is so common for me to find people that have had hysterectomies at the age of 25 after a long spate of pelvic type of illnesses, because that's the male fix for female problems, taking out the uterus. And then they have no relationship, they have no children. And when there is these are critical parts of a person's development. I'm not saying that everybody needs to have a child, but many people, if they don't have children in their lives at some point in time, have a sense of emptiness. And I tell people all the time that these are goals to be reached out for. And if we as therapists do not nudge people in that direction, then we are not helping them come towards healthy recovery, and we are leaving them open towards the potential for relapsing or going into some kind of cross-addiction, as we looked at previously. And of course, I can't, I have to always mention, I usually write spiritual recovery like along the side, because to me it is the beginning, the middle, and the end of all things. And so it has to have a continuous growth through time. Developing networks, doing physical exercise, monitoring sleep, appetite, and energy levels. Again, these are the indicators that a person's addiction potential and their trauma has not been resolved. Sleep is a very good indicator. Sleep is like a very basic self-soothing mechanism that we have. It is where we get drawn into nature's lab, which heals our brain. You know, the REM sleep and the non-REM sleep. Sleep that rests one's mind and sleep that rests one's body, doing the work of dreaming. You know, that all has to be in balance. And one way you know it is when a person wakes up feeling refreshed. It's not whether a person has slept 5 hours or 14 hours, but how refreshed they feel upon waking up. And when you look at trauma I like to tell this because I'm always fascinated by the magic of it. But around 2 o'clock in the morning, you have these bouts of REM sleep, then you have non-REM sleep. Okay? REM sleep is when your eyes move around and stuff, your brain gets more blood, then you're awake. And then in the non-REM sleep, it kind of gets turned down. But in the non-REM sleep, there is a phase around 2 o'clock in the circadian rhythm when you go into the deepest level of sleep, which is delta sleep. And it's at that time that your pituitary puts out this burst of growth hormone. Okay? It puts out growth hormone, and the growth hormone goes all over your body, revitalizes your cells, makes new, just like rain falling on a meadow, it makes your cells grow. But when you don't sleep properly, and your sleep architecture is not right, as happens with trauma in childhood, you don't have this kind of steady flow of the endocrine rhythms. And that's one of the reasons why bodily and emotional illnesses are so common. Okay, so sleep is a good way. These are all ways of inventory taking. And lastly, it said provide playtime, time for self-soothing and time for doing things that make a person feel good about themselves. I'm going to stop now. Well, I have another slide. It's about body work. I'll be talking really at length about body work in my next talk, where I have a little bit more time than this one. Okay, what do I mean by body work? It's essential for the therapy. I would add chemical addiction as well. Eating disorders, self-mutilation, sexual problems, on both sides, and people that have problems of violence. Again, these problems are very common in chemical-dependent people. People often take, if they feel violent all the time, they take drugs to calm down. Using the body as a vehicle for retrieving memories, using the body to learn self-awareness, self-soothing, self-esteem. I will send copies of this, so you don't need to really take it down. Sexuality, play, and creativity, the establishment of safe distances. Again, by the very borderline kind of dynamics that people have, closeness and separateness are both threatening. If you move a little bit away, and then they feel distant, too distant from you. If you come in too close, they feel like their boundaries are being shattered and you're being too intrusive. I mean, this is with patients too. I was told during my residency that when you work with borderlines, you have to be careful even when you loosen the top button of your shirt, because you don't know what kind of message you will be giving to people. And I think that has to be, it's a good example, but it has to be borne in mind all the time. I am a very firm advocate for body work, but the essential thing is about building boundaries. It's not about breaking them. Okay. The establishment of safe distances, dealing with compulsion, apathy, impulsivity, and as I said earlier, looking at the whole muscles as a cutting edge of the will, exercise, martial arts, all of this. I look at all of this as body work. Again, important also in treating sexual addictions, sexual trauma, and chemical addictions. Posture correction, improving eye contact, recognizing and healing bodily illnesses, dance, movement, massage, holding, breath work, voice. And lastly, let the patient know that intensive memory work can only be done within the framework of holding body work. I'm going to talk more about this in the part about dissociative disorders. And this is what I call therapeutic body work. Critical again for chemical dependence and sexual. Since you can read this as well as me, I'm just going to leave it there, and I'm going to take questions from you. Yes. Yes. The question is, must specific memories be brought out as a part of having to heal trauma? And I would say, I think it's very helpful, but I don't think it's critical. I mean, ultimately, it's the feeling memories. It's the feeling memories that I call them, the feelings that are most important, because picture memories cannot always be trusted, and this is why a lot of us have been getting heat and a bad name with the general public, and skepticism within the community, and the wrath of the False Memory Syndrome Foundation Society, and all of these things, because ultimately what is remembered is a mixture of many things. There are infantile distortions, real memories with great detail. Then you have fantasies, you have dreams that come into it. So one can never say. And the question is, I know that we're kind of digressing, but I'm sure all of you are somewhat involved in conflicts like this. I mean, how often does ritual abuse happen? Does it happen 100% of the time? Does it happen 50% of the time? Or does it happen 1% of the time? I tend to believe that these things happen. I am not saying that these things don't happen, but we can't always go for picture memories. And there is going to be times, where much of the world, when you look at a child that is 6 months old, the largest, most developed part of that child's nervous system is its sense of touch, its sense of kinesthetics, and there are no picture memories that are critical at that time. And when you see somebody that remembers significantly from age 6 months and age 1, we are talking about something that's pathologic. Why is a child remembering the design of its crib? It is because it is starved of love and affection. Okay? Because that is what you should be feeling when you're 6 months old, is warmth and holding and sense of music coming into your ears and the throbbing of the mother's heartbeat. That's what you should be focusing on, not on whether you've got straight railings or you've got circular railings on your crib. So this hypersensitivity and hyper recall of single sensory kind of things, whether it's picture or sound. To me, it's part of a pathologic process. I hope I have answered your question. I know it tends to be a little convoluted sometimes. Yes. Well, thank you for allowing me to do my little pitch for my center here. Okay. Okay. The average length of stay is 10 days to 2 weeks for the inpatient. We don't tell anybody they're going to get better by the end of that time. A lot of times it just means that people are going to be having their wounds opened up a lot more. And again, because of my background in surgery, the treatment of an abscess is you make cross cuts and leave it open so that you start draining from the inside and the walls heal from inside. And I use that example all the time. So I feel that people are that much better off if their wounds are opened up rather than left covered, because you don't know where the pus and the germs are going to wind up next and who is going to get hurt. Okay, so at the end, so 2 weeks and then followed by 2 or 3 weeks of which does about 70% of the work. Now, a lot of professionals come into the program both to learn about it. You come into the intensive day treatment program, which is very inexpensive. It's $695 for a week. And we started it because we wanted to deal with people that didn't have insurance benefits and who couldn't afford going inpatient. And because we have a self-selected population, or referred by therapists a lot of times, who know their strengths and their weaknesses, we don't have people that are decompensating all over the place, even though they have to stay in hotels or in homes outside of the center, and they do fine. But meaning our experience, even with doing a lot of abreactive and memory work, is that people have the strength. You know, when you have lived 40, 50 years, you know, gone through abusive marriages, raised children, seen grandchildren, seen people die, all of this, it is our, in a sense, it is our failure to acknowledge that this is the same person who, as a child of 3, 4, and 5, you know, stood in front of a mother who was being beaten, held back a scream when her stepfather was raping her. And if they had the courage and the togetherness to hold it at that time, you can bet that they are not going to fall apart. They may feel they're going to fall apart, but the feeling of powerlessness is very different from what one actually does in life. Okay? So I'd say like a total of 3 to 5 week period, depending upon that. But the emphasis again is on what gets done after that. I think it's very, very critical what's done after that, and which again takes us back to 12-step work, body work. For us, we also emphasize that people watch the videotapes. We do narcoanalysis, and which is one form of hypnosis using chemicals, which I'm going to talk about at length, because it's something that we have done. We do a lot. Again, something that is not real popular with much of the community, both medical and non-medical, because of the intrusive nature. But we do a lot of it. We do much more than what we did 5 years back because of the results that we've been getting, and it sent people right out at the end of that time. And so some people will come in for a week of day treatment only, and there will be other people that may stay maybe 3 weeks inpatient and then maybe do a week or two outside. But the most critical thing is watching these tapes, getting body work, exercising, being in therapy, having sponsors, winding down abusive relationships, winding down abusive jobs, those kind of things, really emphasizing. And treatment failures always come. So what I do is like, I do a telephone contact 2 weeks after that, 3 months after they leave the hospital, to kind of fine tune. And the things that people don't do are, they're not staying connected to the trauma and working through it. They're not attending 12-step meetings. They're not exercising. They're continuing to live in abusive relationships. Those are the kind of pitfalls that ultimately therapy doesn't overcome. Let me take a question from this side. Yes. Yes.
You were mentioning that a lot of times the specific trauma doesn't have the specific picture memory doesn't have to be brought out. But in the case of PTSD,
Well, I mean, I've always stood out as the advocate for drawing memory. I think it's good, but I don't think it should be the only goal. And I don't think that one should be left with a sense of saying, nothing's worked because I didn't bring out picture memories. So even if there is a situation where picture memories cannot be brought forth, one still should not look on it as if treatment's not working or one's recovery is not working as long as picture memories are brought out. And then you also find, because as I was mentioning, be able to accomplish picture memories at some time in one's life because one cannot put together the visual information, so what you are left with is feelings. The feelings of rage, feelings of annihilation, being torn apart. How does a child, an infant, translate a mother's sense of intense depression, apathy, and deadness into itself? It feels a sense of annihilation. What does a child that has a sense of annihilation, not existing, respond with? It deals with the sense of rage. Annihilation is responded to by rage, or you have an anaclitic picture where the child just withdraws and often dies or gets very, very sick. So these are still very much feeling memories. I push very, very hard to get picture memories, and I'll tell you why I push very hard to get sensory, what I call picture memories. Because I think that picture memories give one a better sense of compared to the pictures that people remember, abuse is such a tame word. When we talk about the graphics of how people are abused, the actual situations of abuse, the word abuse is very, very is unempathetic, because that is what brings out the real pain. Talking about and knowing the specific, it's very, very helpful. So I will push very hard for that, but I won't see a lack of it as saying that it's not good. I think, on the other hand, pushing towards it is very helpful. But we can never tell a patient, for example, that everything that you remember is accurate. Only they can validate that, and it is by living in life, carrying on in relationships, becoming sexual, taking on new quests, being creative, that what is real becomes more and more real, and what is distorted dream material and fantasy begins to fall by the wayside as not real. So as a therapist, because we know as therapists, people may make up very, very trivial things. Okay? People may either make up, distort, or even lie about very trivial things. And there may be horrendous things that may have gone on in their lives completely beyond a person's belief. That may be very, very true. You've heard of Ellen Franklin's case. The number of cases of people actually remembering documented stuff about atrocities happening on children, siblings that have watched their sisters being killed, brothers being killed, mothers being killed. There's so many that we know horrific things are done to children. If you look at the deaths in children, the most amount of killings take place in the very young, not in the ones that can get up and run. It's the ones that can't move around that get beaten and abused and killed. So we know these things happen, but we cannot always validate that for them. They have to come to the realization of validation and connect to the sense of hopelessness and terror and rage and the capacity ultimately to come to terms with it and grow beyond it. Yes? Non-dominant handwriting, in a sense, I think about it as a hypnotic process where one gives permission to oneself to express one's not often expressed, weaker, more shameful, or more I don't think about it like an altar comes into the left hand and starts working it. My concept of MPD and stuff is very different from most people, and one of the things I tell people all the time is you don't have to be a special person to treat things like that. I'm going a little bit to the side, but I'm talking about non-dominant handwriting. Left-hand writing in people that are right-handed and right-hand writing in people that are left-handed. What's that? Right. Well, there's various forms of breath work. It's not my specialty, but there are many therapists that do breath work. One is the usual stuff that Stanislaus Grof, and there's another lady that trained in a Stanislaus Grof that sometimes does breath work in these conferences. I forget her name. What's that? Janet Small? Yeah, I'm not sure, but yeah. But again, it's just integrative work, having people get in touch with feelings. I have some knowledge of it. I mean, I could probably. It's not something that I have hands-on experience, but we do that. I mean, there are several therapists that do that routinely as a part of the program, as a way of doing abreactive work, getting in touch with memories and feelings. Yeah. Yes. Well, I have to give you a heretical answer here, because I'll say it at the same time, because as long as the trauma issues are not being addressed, then real recovery in chemical dependency cannot take place, and one leaves oneself open for relapse. If there are things that are coming out on account of attending incest survivor meetings or doing therapy that is focused on trauma, then what they need to do is they need to up the amount of meetings that they need to attend. That's the thing. It's not about saying, I think I'm going to do this. You know, life doesn't wait. You don't have 10 years to work on alcohol problems and then spend the next 30 years working on that, because there is a continuous trail of devastation that is going on while these addictions are not being addressed. So trauma work has to be done simultaneously, and that's what I'm going to be talking about. One has to create a holding environment for bringing up trauma. The burden of creating a holding environment falls upon the survivor. If a person says, I'm glad I'm not drinking, you know, but I don't think I want to do trauma work, but continues to be in an abusive relationship, all of these things, then in a sense they are only doing part of the work while still continuing to be damaged, you know, damaged, cheated, possibly abusing. So I feel that it needs to go side by side. It needs to go side by side, and yes, there is always, because the other paper, the paper that I originally going to present, I had a list of cases where we showed that it is when the sexual trauma is, unresolved sexual trauma is what causes very often chemical dependency relapses. I mean, so you want to look at it. Somebody that could not either sexually acted out or could not. I mean, we had one person, a Vietnam vet, that came in for the second hospitalization. I had told him that he needs to attend sexual trauma meetings and perpetrator type of meetings, and he never did. He was always, he had been in a sexless marriage. Both of him and his wife were recovering people. They went to a party. She drank some champagne. She tried to make love to him. They had not had sex for like a year and a half, and he became panicky, acted out sexually. His thing was that he would pay people that would insert things into his rectum, began drinking, went into binge drinking for 9 days, got completely wasted, was re-hospitalized. So to me, that if he had been working continuously on his sexual trauma and his sexual addiction, then that relapse would not be there. And one does preemptive work. I mean, part of working with trauma is to be preemptive. So trauma work and addiction work go side by side, but not in tandem, because it's a setup. Because people use drugs to sexually act out, and then vice versa. So it has to be done together, not in tandem. Otherwise, you're looking at just a spread out time that is unnecessary. And I know this is not real popular, but I'm talking about our experience, and I without a doubt, I will push that. all feelings are going to go up. I mean, but the issue of suicide attempts. Suicide is something that we have to see all the time as part and parcel of survivors' pathology. I mean, suicide for survivors is like a little marble that they handle, something that they move to every time. It's a kind of defense a lot of times. It's what a child that has no place to turn to goes to, plays with, thinks about, dreams about, fantasizes, talks about, projects into things that he or she sees in TV. They live with it all the time. So having suicidal surges is not a reason for not working. We expect that every person doing intensive trauma work will have to deal with suicidality. And what we tell people that you have within yourself the capacity for self-preservation. If you've made it up to age 45 to all of this, you're going to be able to make it, that there is a preservative part of you, and that's the part of you you stay connected to. Because in truth, as therapists, talking with somebody on the telephone for a half hour longer or putting them on closer checks is not. I tell people all the time, it only takes 15 minutes to kill yourself cold. You can throw a towel over the shower head and hang yourself cold in 15 minutes, between 15-minute checks, or walk down to the freeway and take a drop in front of a 24-wheeler. There is no way as therapists we can stop somebody from killing themselves. Okay? No way at all. And the burden of staying alive always has to remain with the patient. Always, always. And for us to say that somehow we have within ourselves the capacity to keep you alive is to tell them a lie, because we don't. And we take away from them both the power and the accountability. But I think that creating a safe environment is important, but we put it on them. Okay. Sometimes we use medications, and I'm going to talk more about some of the medications that we use.